Hello, my name is Julie Tesh, and I am the President and CEO of the Center for Rural Policy and Development. We hope that you're going to enjoy our discussion and webinar today on rural healthcare in Minnesota. We have a lively panel discussion on the second half of our webinar, and on the front end we have great research from the center. I hope that you will be able to check out our website at ruralmn.org to sign up for our website and to look for all of our research. Thank you very much. We are a nonprofit organization. We were started as a think tank to bring greater Minnesota ideas together. We're nonprofit, we are nonpartisan, we're non-biased, and we're dedicated to providing policymakers with an unbiased evaluation of issues from a rural perspective. That is what we do, and I think we do it very well. What we do is we take those complicated and complex issues and we present them in ways that give them meaning and relevance. So our research, it really isn't designed to determine public policy, but instead to inform those making decisions. So when we're talking about rural healthcare, we all know that healthcare looks different in a rural part of the state as an urban part of the state. And so when we're discussing and looking at rural healthcare, we're looking at it from that vantage point. And our goal is to really be able to provide good, non-biased, nonpartisan information to policymakers at all levels of the state. I get a lot of questions on how do we actually come up with our research agendas. Is this just something that you and your staff do? And the answer is no, we actually gather a lot of input. So we as a staff will come together, put some ideas together, and then we have a research committee on our board. We have 19 board members, and then we send out a thought leader survey to about 1,500 decision makers and influencers across the state. And we have them take a survey and tell us about what's going on in their rural communities. And then from there, we typically select 4 to 6 topics that are passed by our board. Our wonderful staff, we all live and work in rural Minnesota. We are virtual. We were already working from home before COVID hit. So Kelly Ash, who you're going to be hearing from today, is our research associate. He is in New London. Marnie Werner is our VP of Research and Operations located in Mankato. And myself, I am located on my family's farm near Waldorf, Minnesota. So we are a small but mighty group and very proud of our team. Just quickly for our board of directors, if you want to take a look at this more, you can actually go to our website at ruralmn.org and to take a full look of our board members. But we do have 19 board members. 16 of them are appointed by the governor's office. The other ones are appointed by our board. Want to give you a quick rundown of our resources because this is the first time we're doing a live webinar. And so we're very excited about that, and we thank Sourcewell and we thank Heather and AMC for that. But wanted to let you know again, our website is ruralmn.org, and you'll be able to find all of our latest research there. We have some great research on the workforce dilemma. Can wages go further in greater Minnesota? And the answer is yes, they can. And then also transit for healthcare, volunteer drivers, and aging rural Minnesota. Those are just 3 of our most recent research studies along with healthcare. And we'll be having an update to workforce here in November and then throughout the coming months. So please make sure that you go to our website, and then also you're able to do a search to find other aspects of research as well. So we've been around since 1997. We have a lot of research to offer you. We also have a podcast called The Center of Everywhere, and this podcast is featuring people and organizations across rural Minnesota and people with rural Minnesota interests. So the Citizens League, the League of Minnesota Cities, we've had Redhead Creamery, we've had Sue Grafstrom from Roseau County, Santo, Cruz. We have a whole list of people that we've had. And the reason we call the podcast The Center of Everywhere is because a lot of times in rural places, we hear about, oh, you live in the middle of nowhere. When in reality, we think we live in the center of everywhere. So that is the podcast. Please check that out. That's on iTunes, Spotify, and all of your major streaming. Also, we have a blog series. If you go to our website, ruralmn.org, we try to post a few of those a month just on very different topics, quick reads for you. And actually, next week, our blog post will be talking about the census and redistricting coming up. Also, we have videos. We have a nice assortment of videos. You can go to our website or go to our YouTube channel, Center for Rural Policy and Development. And we have videos, and that is also where this webinar, this live stream, will be uploaded to next week. So you'll be able to view this live stream, well, recorded, not live. So, and for our research, like I said before, we're working on the redistricting, consolidation, working on some podcasts. We'll be having rural grocery stores, a podcast. We're doing census and redistricting. And then our other research reports also are going to be the impacts of COVID on the rural workforce. That's the one coming out in November. Also, we're working on a child care study. And then agriculture, land values, and impact on rural infrastructure, obviously very important. And then the shifts in county revenue sources, between the farm crisis, shopping at home, dark store theory, there's a lot of shifts in county revenue, and how is that really going to be affecting taxes and everything, infrastructure there. So a very quick rundown. If you would like to stay up to date on our information, you can again go to our website. We have a monthly newsletter you can sign up for. It is ruralmn.org, just like the slide says. And we promise not to spam you. We will send you our monthly email, and then also our monthly newsletter, and then we'll also send you invitations to webinars like this. We are planning to do more webinars, whether they're live or via Zoom, but make sure you sign up for that newsletter and you will be part of all of the great information. And then also we're on social media, so check us out there. We try to stay accurate and active with all of those, so please like us and friend us on there. I am going to turn it over to our wonderful and amazing researcher, Kelly Ash. There you go.
Great. Thanks, Julie. And thanks, everyone, for joining me. I really appreciate the opportunity to present this research that we've been working on for the past few years. Before we launch into this, I do want to provide just a quick introduction or framework on how today is going to proceed the next couple hours or hour and a half or so. Really, the big goal for today was to provide all of you folks, the rural leaders in Minnesota, a tool set for you to be able to collaborate and engage with your regional and local healthcare providers. There's a lot of changes happening. It's probably going to get even faster changes throughout the state due to COVID-19, and this is a perfect time to start having those conversations with your healthcare providers to figure out collaborations. And this tool set is going to first start out with giving you some context and knowledge about the shifting kind of healthcare market that's been going on over the past 10, 20, and maybe even 25, 30 years. So you have an understanding of what our healthcare providers are facing, because that will make it easier to relate to your healthcare provider and start having those conversations. And then you'll also start to understand why some of the mergers and acquisitions are happening in your local area and why you might be seeing some changes in your region. We're also going to hear from some panelists in the second half of this live stream. They'll be able to provide us a bigger, broader definition of what rural healthcare access can or should look like. This is a big question because we kind of have a lot of different ideas about what access should look like, but we have one person that's really going to help us nail that down a little bit more and give us some really deep insightful answers to that question, as well as hearing from some local healthcare system administrators to tell us kind of what's going on the ground right now, what are they feeling from their local healthcare service providers, and give us some kind of examples and ideas on how local regions can collaborate and move forward with their healthcare providers. So without further ado, let's launch into some of the research here so you have a better context into what's happening. And this is the research question we were looking at. What is the cause and impacts of healthcare service consolidations in rural Minnesota? This actually started out as a question about what's going on with all the mergers and acquisitions in rural Minnesota. And you could probably say the state of Minnesota. It's not just happening in rural areas. But we started there, and as we did this research, we realized that, oh, actually we need to go back and look at the context, the financial market in which our healthcare providers are being paid and the shifts happening there, because that's what's driving mergers and acquisitions and other changes in healthcare and will really shape the future of healthcare. So let's look at that, a shift in payment philosophy. So Over the past 20 years, we've seen a shift away from what we used to call fee-for-service. Those were healthcare providers being paid based on the number of services provided or the number of procedures ordered. This kind of incentivizes a higher cost heads in the beds model, right? It wasn't based on, did you get healthy, then we'll pay you. It was, I'm going to have an x-ray, and then I'm going to have a doctor visit, and then I'm going to have some consultation with a dietitian. All of those are separate payments. You have to pay for each piece, or whoever, the insurance company or Medicare or Medicaid, are paying for each step of those and paying for each patient to do that work. Well, back in the 70s and 80s, when healthcare research was coming out, one of the big themes was that we were paying a heck of a lot for healthcare with not great outcomes. And so through the conversations over the past 20 to 30 years, a new model has been rising and has been getting a lot more support and policy changes to try and incentivize lower costs and better outcomes. And this is that shift towards that value-based care. And you'll see that on the right side here of your slide. Providers are reimbursed based on the quality and efficiency of the care they provide. Well, what does that look like? This is kind of just a real basic theoretical difference in those. So on the left side there, we have, this is what we would call the fee-for-service. So each patient goes through a thing, goes through their services, goes through their consultations, whatever they're going through, and then ends up that the payer, it could be the private person, it could be an insurance company, it could be Medicare or Medicaid, then just paid afterwards after all services are done, saying this is what had all to be done, here's what it costs. The shift, though, is on the right side here, and this is just an example of, instead of paying for each individual patient, one idea and one model that's actually being pushed is that a payer, let's say an insurance company, can say, hey, service provider, healthcare provider, we have 10,000 patients, 10,000 clients that go to your healthcare system or provider to get services. We're going to give you a lump sum of money, and that's all you get. It doesn't matter if they all have diabetes, it doesn't matter anything, what kind of services they get. This is your chunk of money. If you can provide for them at a lower cost, then you keep the profit. If it costs more than that, that's your loss, and you need to figure that out. That's kind of the shift that's being happening. So this is a value-based philosophy examples. Here we got global payments to providers. So that was kind of talking about, we're going to have somebody come in, a payer, and pay for a whole group of patients and say this is your payment. There's also episode of care payments as an example. So this might be an insurance company or Medicare or Medicaid negotiating with a healthcare provider to say, hey, for everybody that goes through, let's see, diabetes type treatments, they're getting a certain lump sum. It doesn't matter if they're worse or not so bad. This is the sum that they all get. You guys need to figure out how to make that work for yourselves. And then also a big shift is a team-based holistic approach to care. Some of you, actually, I've noticed over the past 10 years since I've been going to my annual checkup that it's not just my physician I'm talking to anymore, but also a dietitian or a nutritionist or other folks where they're actually working as a team for my care to make me better so their outcomes are better, so I don't have to see them as often. That means maybe more profit for them, and it means better outcomes for me. This is the shift that you see happening. And healthcare providers, because of this shift and this push, have to adapt. They have to apply different strategies. And these are just like the kind of 5 main themes that you're seeing that providers are implementing. The first one is risk sharing. This is just like any sort of insurance company, right? Car insurance or anything. You're going to have some patients that cost more and require a lot more services. And then you're going to have a lot more patients that don't require as many services and don't cost as much. You're sharing that risk. And that's what a lot of healthcare providers are trying to figure out how to do, is trying to do that risk sharing, because they're no longer being paid by individual services by individual patient. They're being paid a lump sum, given a budget, so to speak, and then trying to figure out how to make that budget work for them. Upgrading technology is a big one. Actually, the ACA that was passed in 2008, 2009, that was one of the big pushes for that, was to get everybody towards online medical health records. You're seeing a lot more technology being used and things like that. And so the upgrading technology is a big push for that. Developing enhanced coordinated care, that's kind of that team holistic approach. You want to see people that are able to, or a hospital system wants to be able to provide an entire series or buffet of services in-house in order to take care of their patients and increase outcomes and lower the amount of times they have to come. You're seeing a lot more utilizing efficiencies. So this might be something like a healthcare provider being able to buy supplies in bulk so that it's less cost per unit. And then the last one is negotiating higher reimbursements. It's actually no secret that particularly Medicare and Medicaid reimbursements are typically quite low. They don't typically meet hospital providers' true expenses to care for those types of patients. And so they'll sometimes try to negotiate higher reimbursements from privately insured company or private insurance companies to help make up for some of the loss in Medicare and Medicaid. I have one question here. If provided a certain lump sum, what is the incentive for the provider to provide excellent care? The idea is that if they're given a lump sum, they're incentivized that the patient won't come and use your services as much. So if your outcomes are better, that means you won't need as many services. So if you're getting a lump sum, then I get to keep that money because I'm not then continuing to provide services for that patient. That's kind of how it works. That's the tension, if you will, between a lump sum and then making hospitals accountable to having that lump sum and making it as profitable for them as possible. Thanks for the question, by the way, and please feel free to ask as many questions as you want. So what does this shift look like for rural hospitals in the new payment philosophy? When we first started this research, there was this kind of attitude, I think, among a lot of citizens that these larger hospital systems were just coming in and gobbling up all the smaller hospitals and clinics and physician groups as if they had no choice. But once we started going out and interviewing a bunch of physician groups and doctors and even folks that have been recently merged, one theme was that there was a desire to be acquired. As one doctor in central Minnesota explained, when we were looking at our future projections, we knew we couldn't make it on our own as a smallish physicians group. We knew we needed to merge with a larger system to help our financial outlook. And that was a really common theme that we heard when we did our interviews. So why? Well, the issue is, looking forward with this new payment philosophy, is that a small patient pool means that it's much harder to do risk sharing. You have less capital to invest in upgrades for your technology. You can't utilize efficiencies because you don't need to, let's say, purchase supplies at bulk because you don't need as many supplies. And you don't have the leverage to negotiate the higher reimbursements. And so this is really the small patient pool conundrum. This is the reason why you've seen hospital groups and systems get bigger and bigger. I have a question here. Can we get a copy of the PowerPoint so we don't need to take notes? We absolutely will send that out. No problem. Another problem issue with our rural healthcare providers in this new payment philosophy is a struggle to attract specialists. As many of you know, probably if you're living in a rural area, that your local or regional clinic or physicians group or hospital or healthcare provider may only offer so many specialties. And you have to seek specialty outside of that facility to get what you need. Well, right now with the new payment philosophy, there's a lot more incentives. They're really incentivizing hospital groups and facilities to try to have that kind of coordinated care, that continuum of care across their entire group and work in a more holistic fashion. And if you don't have that in-house, that means you need to contract with somebody outside of your hospital clinic. And that can be expensive and it can be challenging and more difficult. And so a lot of our smaller independent rural healthcare providers, if you don't have that specialist group, you're just losing out on some of the incentives that are available to them through this new payment system. And then the other thing to keep in mind is that rural healthcare just costs more. People are typically older, typically a little sicker, and typically a little poorer. And we actually looked at all the financial records for every hospital in the state of Minnesota. This is going back to 2018 now. And as you'll see, for hospitals, this is just hospitals, not all healthcare providers, but all hospitals in the state, ones that were located in our entirely rural areas, the average margin, that's profit margin, was 0.1%. We consider, and most economists and financial folks will consider 4% margins to be a healthy margin for a hospital. That means you're making some profit so you can reinvest back into your facilities or upgrade your technology or hire on more staff. And so the average for our entirely rural hospitals was 0.1%. And in fact, 69% of the entirely rural hospitals had unhealthy margins. They were not at the 4% at all. And as you can see, as a hospital is located in a more urban area, the average margins go up. And the percentage of hospitals that have healthy margins continues to increase as well. So as we get to our entirely urban hospitals, they had an average margin of 6.2%, and only 32% of their hospitals had unhealthy margins or margins below 4%. So this kind of shows you just that rural healthcare in general is challenging. So large is the name of the game. Large patient pool plus a small patient pool. So you can think of a larger healthcare system coming in and merging or acquiring a smaller physicians group works, in theory, works great for both groups. The larger healthcare system gets to increase their patient pool, maybe gets access to more folks, and the smaller patient pool, so the smaller hospital group or healthcare group, is able to take advantage of the larger healthcare system, either through specialists and things like that. So this means that you can do risk sharing. They have more money to upgrade technology, develop enhanced coordinated care, utilize efficiencies, and also negotiate higher reimbursements from those groups. That's kind of what this means. So for our rural hospitals, on top of having to struggle with this payment shift and just the reality of providing healthcare in a rural area, now we have COVID-19. And this has really impacted a lot of revenue streams for our healthcare providers. And we're likely going to be facing some options for cost cutting. It's just going to happen. And really it kind of falls into three main categories. They're either going to have to, one, eliminate services entirely, two, relocate services. So it might be taking a service away from a smaller healthcare provider and consolidating it and moving it to a larger healthcare provider where they can maybe provide it more efficiently. And then also the one that's real scary is the elimination of staff. And most of you might not know, but healthcare in general is a major employer in many, many rural Minnesota counties. It's always in the top 5 major employer in every county in the state. And many times it's in the top 2 or 3 as far as percentage of employment in a county, particularly in rural Minnesota. And those are generally pretty good jobs that pay well and offer benefits and are just good jobs. So if we're talking about this kind of shift and looking towards the future, we kind of got to know what access looks like today. And when I talk about access today, we're looking at it in a pretty narrow way, and we're going to hear from one of our panelists about how we should need to start broadening what access looks like and how we should define it. But today we're just going to talk about where they're located and the distance to travel. This is from the Minnesota Department of Health. They do a great job tracking a lot of this stuff. And as you can see, this is looking at rural hospitals, looking at service declines due to hospital closures, consolidation, or service loss over the past decade. And on the right side, you can see the percent change of those services offered in rural Minnesota from 2009 to 2018. You can see things like inpatient surgery, outpatient surgery, both down about 10%. Detoxification services are down 30%. Computer tomography scanning, 7%. And you can just see that there's a lot of decrease in the services that are offered in rural Minnesota. One that gets talked about a lot is birth services, obstetrics. 2003, we already had quite a few counties that didn't have birth services located within their county. By 2018, there was 9 more counties added. And you can see on that right map there that the counties that have kind of little lines drawn through them, those are counties that were added after 2003 that had loss of hospital birth services in their county. And now we're talking about quite a few places. The most striking for me is in Northeast in the Arrowhead there. There's no one. There's a lake on the south side, and there's Canada on the north side. So folks up in the Arrowhead region, you're having to travel a long ways to give birth, and that's scary. We looked at the average miles traveled for just a few specific inpatient services, just to kind of get an idea of like, okay, what's the average that people are traveling depending on where they're from. And we kind of broke it down by patients that were from our entirely urban counties, from urban town rural mixed counties, our town rural mixed counties, and entirely rural counties. These are where the patients traveled from, or where they reside and where they traveled to. And you can see for cardiology, our entirely rural patients and our patients that live in town rural mixed counties had to travel on average about 75 miles compared to our entirely urban patients where they had to travel about 20 miles. For neurology, I mean, we're talking about 100 some miles, and that's a pretty specialty care service. So not too surprised, but again, it's 100 miles that entirely rural patients and town rural mixed patients are having to travel on average for neurology services. Obstetrics, a little bit less, but again, entirely rural, we're talking about 40 miles on average having to travel for obstetrics. So there's a little bit of rural frustration, and this is kind of what we are hearing on the ground. I think this is what a lot of legislators hear. I think it's probably what a lot of county commissioners and rural leaders are hearing, is this frustration in rural. And I think they think, well, it's all these big systems coming in and taking over our smaller healthcare providers, and that's where the frustration is kind of being plopped on. But what I hope we kind of saw here is that actually it's a whole shift in how we're trying to pay and shift the way in which healthcare is delivered and the outcomes that are really kind of leading to some of these, I would say, negative impacts on our rural citizens. And so there's some frustration. A lot of this came from Albert Lea. As many of you know, the Mayo trimmed some of their hospital services over the past few years. Particularly obstetrics was a big one. A lot of folks get pretty upset when you take away their birth services from their county. And, you know, Albert Lea was unique in that it kind of organized. Its community rose up a little bit and said, hey, we want to organize around this. We don't want this to happen. And so they organized and they attempted to negotiate with the Mayo, but the Mayo has a certain reality that they were facing and couldn't negotiate. And so that group actually hired a couple consultants to come in and do a financial feasibility study. Can we offer a level 2 trauma acute care facility? Is that actually feasibly possible in Albert Lea? And the feasibility studies came back and said, yeah, it is possible. With the right patient pool, it could work. And so that group actually ended up sending out a request for proposal to some of the hospital systems in their region to say, hey, would you consider opening up shop here? And one did end up coming back and saying, or a couple of them did, and they ended up choosing Mercy One. It's the largest hospital system in Iowa, as a hospital system that's actually going to come, and they're setting up shop in Albert Lea. With the plans of over the next 5 to 10 years to have a level 2 trauma center there. You know, whether that's going to succeed, we'll just have to see. But it brought up some interesting things for us. One, when we were doing these interviews in Albert Lea and across the state for other folks that were a little frustrated, the big thing that came out is that there was a desire for local input. It really felt like these decisions were being made with no sort of input from local groups about how they felt about it and how they could maybe collaborate to make this work a little bit better. And so that was a big takeaway for us, is that these things were just happening and people felt kind of powerless. The second piece was that there's a need for assessments. Right now, these consolidation of services that happen in rural Minnesota are happening, and there's no sort of system in place to begin measuring what impact does that have on access. And that's a really big question, because it kind of floats around like, you took this service away from us, I have to travel more now. Is that okay? Do we have a public transportation in place for folks that maybe can't drive? Those are the types of assessments that really don't seem to be getting done when these types of things are happening, and they're probably going to happen more in the future. And so that was a big thing that we really wanted to see happen a little bit more. And then the third one was, hey, maybe there is a little room for competition. If Mercy One is willing to come up and maybe challenge the Mayo a little bit in Albert Lea, I mean, they're a business. They have to make the best decisions for themselves. So there might be a little room for competition, which I think for many folks, past 20, 30 years, consider rural Minnesota as just an area where there is no healthcare competition. That's the problem. But that may not be completely true. So we came up with some recommendations, and a lot of our recommendations are just kind of suggestions for policymakers in particular to kind of take a look at. They kind of fall into a couple different groups. So the first one is requiring a review of consolidations of services. This is really about if a hospital or a healthcare provider says to a community, hey, we're shutting down this service because it's just not financially feasible for us anymore. Maybe there should be a system in place where either the Minnesota Department of Health or somebody comes in and says, okay, but we're going to do some assessment on what are the impacts to access now. Because that's a big question, is, well, what does that mean then for folks? Can they still access this service? Can they travel the extra miles? Do we have a system in place that can assess that? You know, what's interesting is if you look at the Mercy One in Albert Lea, we do actually have a system put in place, but it's actually for healthcare providers that want to open up hospitals in a rural community. So right now, Mercy One, if they decide to move forward with their Level 2 trauma center and open up hospital beds, the Minnesota Department of Health and the Health Economics Program actually steps in and does an assessment on, okay, are you actually needed? Do we need more hospital beds here? And this is left over from the 1960s and 1970s policies that were put in place at the federal government. They got rid of them recently, back in the 80s and 90s, they started getting rid of this policy. But it kind of stuck around here in Minnesota. And it was really to try and make sure that we weren't providing more hospital beds than were needed, because that will just increase costs. Well, we're a little bit different environment now, where maybe we could actually switch that. So if a healthcare provider says we're taking away hospital beds or we're taking away services, there's a process in place that says, whoa, okay, let's assess this and figure out like what kind of impacts that's going to have on access, and have we really identified all alternatives possible. And some of these other then recommendations are really trying to get at, as we continue to think about rural healthcare policy, that we look and treat rural hospitals and rural healthcare providers differently than our metro-based ones, because they're very different markets and they're very different, I would say, environments that they're working in, particularly with the finances and the number of patients in their pool. They look differently, the number is different, and so it just is different. And so even if a entire big hospital system has hospitals and clinics in a rural area, but they're headquartered in a metropolitan area, our policy should still differentiate that and not treat all of the providers within that healthcare system as metro-based because the headquarters is in the metro area, but rather they then get to treat their places differently according to state policy. So that's our research. We kind of just blew right through it. There's a lot more there. You can check out our website, ruralmn.org, to read the full report. But that kind of gives you a good context and foundation for our next step, which is really going to open up to our panelists and start talking to them about just kind of how do we define rural healthcare access, and what might it look like in the future, and what does it look like today, and what are some of the ideas that we can implement from a local region or even a local community, and collaborating more with our healthcare providers to assess access, provide access, and all that kind of work. We got a ton of responses to our prompt over the break, and I just kind of want to go through some of the main themes that we saw of folks responding. One was that there was actually a strong agreement that people thought, yeah, it is definitely possible for our regional leaders and our regional and community groups to start having and collaborating with their healthcare providers, which is really great to see that folks thought that that definitely is a possibility, and in some cases that has been happening, which is great to see. But there were also some folks that said, we don't know even where to start. One response said, we kind of look at our healthcare providers as a bit of a black box. We just don't know how to approach it. We don't know who to talk to. And really, what is the incentive for them to work with us? Which was kind of a common theme that we also heard when we were out interviewing local leaders about healthcare. There's some other shifts that folks talked about, particularly insurance plans, now incentivizing rural patients to seek care at larger metro-based systems, and even making access possible through travel reimbursements and other incentives. Telehealth was brought up as an interesting way to increase access, which is absolutely true, and we've seen that a ton now over the past year, a couple years. And that there was also a lot of concern around what we typically see when we talk about rural healthcare is access to opioid dependencies, addiction treatment centers, and things like that, which has been a long struggle for rural areas across the entire country. And in rural Minnesota, we're definitely seeing that as well. And what would that collaboration even look like to try and bring access to those types of treatment centers? What would that even look like in rural Minnesota? So I think there are a lot of questions there. Thanks again for responding to that prompt. Really, really appreciated it. And those prompts actually represented the poll quite well when we brought that up. Majority of people said that they have had conversations with their healthcare providers, or know of groups, at least in their local regional area, that are having conversations with their rural providers to increase access or to have conversations about programming and things like that. But then a fairly large percentage, of about almost everybody else, said they didn't know, which is probably pretty typical of most rural areas trying to understand all of this and how it works. And I think there's also some questions about who should be having these conversations in our regional community. Should it be city council members, county commissioners, and things like that? And those are some of the questions I hope our panelists can help us answer today. And our research for this year on rural healthcare, when we presented last year to legislators and other leaders, one of the big questions coming up was, how do we define rural healthcare access? What should that even look like in a perfect world? Under this new kind of payment philosophy, this kind of shifting market and how we're paying for these services, we know it's going to change delivery methods. So what are some of the alternatives? What might that look like, and what should access mean? And when we started digging into healthcare access, has any other organization started defining this, we ran into RUPRI, the Rural Policy Research Institute, who has been a leader in talking about rural healthcare access and laying out some really interesting frameworks of how to measure this and look at it through a rural lens. And that was really cool. And we were excited when I was reading through the report. One of the authors and is on the RUPRI healthcare panel as an expert is Jennifer Lundblad, who is here in Minnesota and is the CEO of Stratis Health. Let me provide just a quick introduction for Jennifer, and then she's going to take it away. Dr. Jennifer Lundblad is the president and CEO of Stratis Health, an independent nonprofit organization that leads collaboration and innovation in healthcare quality and safety, and serves as a trusted expert in facilitating improvement for people and communities. She brings to this panel expertise in change management, dissemination of innovation, process and workflow analysis and redesign, rural-specific quality measurements, and organizational culture improvement across the continuum of care. She is a member of the National RUPRI Health Panel, as I explained, the University of Minnesota's Rural Health Research Center Expert Work Group, and serves on various other national and local boards and in committee leadership positions. And she's an adjunct assistant professor at the University of Minnesota School of Public Health. Jennifer, I'm going to hand it off to you, and you should be able to advance the slides yourself. And welcome. Really appreciate your time.
Well, great. Thanks, Hellie. I'm pleased to be with you today as part of this forum and was delighted to see so many colleagues from across the state on the registration list. Wish I was there in studio with you, Kelly, but instead you have my home office as my background, as is true for so many of us these days. And I'm just keeping my fingers crossed that my dog stays quiet, the perils of working from home. So as Kelly said, and as you all responded in the poll, it's important for rural communities to build relationships with their local healthcare organizations and together to engage in planning and preparing for today and in the future. It's useful for you to be grounded in healthcare access and the unique role that access plays for rural communities to help you lead effectively. So what I want to do today, if I can advance the slide. There we go, is share with you the broader context and vision for rural health and healthcare, and then hone in on access. So when we hone in, we'll talk a little bit about what access is and some key principles. And then I'll introduce some of the current considerations as we think about access in rural, which you might be experiencing right now as challenges or threats to access. And again, I think some of it came up when you responded to the question that Kelly posed just before the break. Then I'll offer some resources for you as community leaders. So as Kelly said in the introductions, I have the privilege of serving as a member of the RUPRI Health Panel, the Rural Policy Research Institute Health Panel. That was established in 1993 to provide science-based objective policy analysis to federal policymakers for the most part. We do a bit of state work as well. And I've been a member of the panel since 2009. We, the panel, developed a vision for what a high-performing rural health system is, and we ground our work in this vision whenever we are writing policy briefs, providing legislative testimony, or offering comments on proposed rules and regulations. So you see here on this slide what that vision is, we have a rural healthcare system that is affordable and accessible for rural residents through a sustainable health system that delivers high-quality, high-value services. A high-performance rural health system is informed by the needs of each unique rural community and will lead to greater community health and well-being. So within that vision, it relies on 5 foundations, none of which stands on its own and all of which are necessary together to achieve a high-performing rural health system. So affordability, accessibility, community focus, high quality, and patient-centeredness. And that leads us really to today's discussion about access. But before I turn to the next slide, I just want you all to pause and each of you in your own mind say to yourself what you think healthcare access is or what it means to you. So I'll give you just a second to do that. So some of you may have said healthcare access is how far I need to go to get the care that I need. Some, can I get the specific kind of care and services that I need or want? Some of you may have said, how long do I have to wait to get those care and services? Others of you might have asked, will I be treated fairly and with respect, which is another aspect of access. Others may have said, do I have the necessary insurance and benefits to get the care and services that I need? So there are many definitions and descriptions of access, and that often gets kind of intertwined or bound up with how we even define rural. And we know our federal government defines rural in multiple different ways, depending on the policy or program purpose. But for today, we'll simply note that access is more complex and multifaceted than you might first think at first blush. So in our Rupri Health Panel work, we've stated on many occasions that primary care, EMS, and public health are the core of vital rural community health services. Even as we acknowledge that there is significant variation in what healthcare services can be supported and sustained in any given community. But we time and time again come back to this notion of primary care, emergency medical services, and public health. And the availability of and the access to these three core services is a principle around which we build our health panel work. We also know that care integration and coordination are essential to assure that patients have access to the full range of care across the continuum of care if and when they need it. So that means from nursing home, skilled nursing care to home health, from dental care to behavioral health and more. Again, some of these are really challenging in rural communities. We also have as one of our principles on the Rupri Health Panel that healthcare services should be available as close and convenient to the patient as possible. And when that isn't the case, which is quite often in rural, then there should be a community planned approach to address access. And there are strategies and tools to help do this, whether that's transportation or technology or provider relationships. Also, there are referrals and communications in place, all of which help assure that the right information is available to the right care team at the right time to make that care accessible for patients and their families. So all of this reinforces the notion that healthcare access is really complex and multidimensional. And we, as a Rupri Health Panel, did a synthesis of the research and literature on healthcare access a few years ago, which led us to identify 4 dimensions of access that you see on this slide. We did this especially for policymakers, people, place, providers, and payment, and the dynamic relationship between them. So this is not a static view of access, but an ever-changing view of access that relies on these 4 dimensions. And for those who are interested in diving deeper, I've included the link to this synthesis, to this longer paper that we have at the end of my slides. So that really leads us to why we've come together today. So what does all of this mean for you as leaders in your rural community, whether you're an elected official or in healthcare or local public health or in a community-based organization? You're facing healthcare issues related to access. You're likely grappling with these today or feeling the effects of these today. And Hellie, in his sharing of their report, really described a few pieces of this as well. So the 3 that I've listed here are network adequacy. So that really refers to a health plan's ability to deliver the benefits promised by providing reasonable access to enough in-network primary care and specialty care, and to all the healthcare services included under whatever that contract is and the benefits described in it. So this is often challenging in rural places as we think about network adequacy. Telehealth, Kelly also mentioned telehealth. It's booming right now since COVID-19 pandemic has prompted changes in both regulation and payment, and as many patients need or want to avoid bricks and mortar healthcare. But will telehealth supplement or supplant care and services in your rural community? And what will happen when the public health emergency is over and some of those regulations and payment changes go back to the way they were before? And then third, again, as Kelly referenced, there have been many hospital closures in rural communities over the past decade, including a few here in Minnesota. And many hospitals and healthcare organizations are operating right now on the financial brink that's really been exacerbated by the COVID-19 pandemic. And we live in a state dominated by large integrated delivery systems. So what are the effects of closures, mergers, acquisitions, affiliations in your community? So I pose these questions that I know we're going to have some time to focus on during our panel discussion, and that my colleagues up next from CentraCare may offer some insight from their health system vantage point. And then lastly, I want to leave you some resources that I hope are helpful for you as community leaders. My organization, Stratis Health, teams up with the University of Iowa to lead a national program called Rural Health Value. We provide technical assistance, we raise awareness, and we engage in communication strategies about leading edge rural efforts across the country. And I've highlighted a few resources for you here on this slide that are most relevant to your role related to this topic of access that we're talking about today. So first is a discussion guide that is really about how to engage the board and the community in value-based care conversations. Secondly, there's a guide for rural health collaboration and coordination. And this is really all about how rural stakeholders can work together to assess and address their rural community's health needs, including how to use the community health needs assessments that nonprofit hospitals do today and that many public health agencies are also doing. And then lastly, we have a series now probably nearly 20 profiles in innovation of examples across the country. And some of those are specific to strategies that address access and creative approaches to community engagement. So again, ruralhealthvalue.org is where you'll find this rich set of resources that I hope can be useful for you. So here are the links to the two reports that I mentioned that I drew from for today, and then my contact information and the three roles that Kelly described when he introduced me. And I really would welcome any outreach or follow-up from this. So with that, I'll pause. I'm really looking forward to the panel part of this discussion, and I'll turn it over to my colleagues from CentraCare. Or maybe back to you, Kelly, first.
Thanks, Jennifer. Really appreciate that. That was perfect. That really sets us up nice to have a conversation about what rural healthcare access should look like coming up here. But first, we want to talk to CentraCare, and the reason that we invited our CentraCare colleagues to join us today was we really wanted some folks that some hospital administrators that were on the ground, had a good idea of where our healthcare providers were financially in our rural areas, was a part of a larger system, to give us kind of what their from their vantage point, what does the future look like? What does it look like today? And what sorts of interesting strategies have they seen in collaborations between local regions and their hospital or their healthcare providers in their system? And so I got two fellows from CentraCare Health Systems. Just so you know, that's headquartered in St. Cloud. They provide healthcare in central Minnesota. They have 6 hospitals, 7 senior care facilities, 18 clinics, 4 pharmacies, and numerous inpatient and outpatient specialty care services throughout Minnesota, most of it in rural areas of our state across CentraCare, Minnesota. And the two people we have are Hellie and Santo Cruz, and I'm going to introduce Joe and Santo here. So Joe is a vice president of strategy and network development for CentraCare. He's been employed in various leadership positions within CentraCare since 1992. In his current position, he is responsible for strategic planning and business development. And Hellie is also accountable for emergency medical services with CentraCare Health. And the other gentleman joining us is Santo Cruz, who's a senior vice president and general counsel. Oh, I'm sorry, you just got promoted, Santo, who is now the director of government relations and senior vice president. He has been a deputy as a commissioner of the Minnesota Department of Human Services, assistant commissioner and general counsel for the Minnesota Department of Ag, and attorney for the Minnesota Department of Commerce before joining CentraCare. He began his legal career as a prosecutor for Hennepin County. Gentlemen, thank you both for joining us, and I'm going to hand it off to you. I know, Joe, you have a few slides you would like to share.
Yeah, thanks, Kelly. Just briefly, a little bit about CentraCare. As Kelly mentioned, we have we're anchored by the St. Cloud Hospital, which is a level 2 tertiary center, 489 beds. And I often describe CentraCare as the tale of two health systems, one being a major regional medical center, the St. Cloud Hospital, and the others, our mission of providing that high-end care, and the other is a deep passion for rural healthcare. We do have 5 critical access hospitals, as well as manage 2 additional. And so what I'm going to take just a moment and talk to you about the system, the health system perspective on rural healthcare, at least from the CentraCare standpoint, but I think it follows with many of the health systems in Minnesota. And as Jennifer mentioned, there's a lot of integrated health systems in Minnesota. It's predominantly 8 or so systems carry probably 75% of all of the beds. And as we look at the pandemic, 90% of all of the critical care is held by those health systems, or in one shape or another. CentraCare by proportion is really at the smaller end, and I want to bring that up because we consider ourselves the really centered and dedicated in rural, central, west central Minnesota. And with that, we're a $1.7 billion company with 13,000 employees, but we are the smallest of the health systems in Minnesota. So I want to begin just briefly with talking about what's called the system of care. This is something that was developed and illustrated by a company called SG2, a healthcare think tank that a lot of us subscribe to. And there's really 3 elements of the journey of a patient. There's the community-based, and it starts with your home. You can access care through electronic visits. There's wellness and fitness, and you move your way up the continuum there to maybe you need an ambulatory procedure, eventually needing hospitalization, and then the journey of what we call post-acute care, which is often rehab, but includes the nursing home or home care. And health systems have, over the last 20 years, really driven their strategy around being part of each element of this continuum of care. And as Kelly illustrated in the first part of the talk, the shift to value-based care and risk contracts, as opposed to what we used to get paid in fee-for-service, really drove the need to be able to be part of, or at least have some say in each element of this continuum. What I want to illustrate, though, is I think we have to start to think about things a little bit differently, and we'll circle back to how that the implications on rural, but all of these market forces that have been described have been at play, but most recently, COVID has shown us that the world is a lot smaller than what we previously realized, and that physical presence is not necessarily essential in all elements of delivering healthcare. So within our organization, we are right now trying to understand. We have this collection of assets of physical bricks and mortar, and so much of our strategy has been based on location. And the changes of late, the drivers within COVID and virtual care have really caused us to pause and say, not that we didn't see this coming, but not at the pace that it is right now, is how do we develop those virtual and digital competencies? What is the consumer looking for? And if we pair that again with the force of thinking about what are those partnerships that others offer, because this concept of owning each element of that continuum of care is probably not sustainable in the future. And so we're really looking for unique partnerships. That's sort of a backdrop on which I would talk about rural healthcare and the partnerships that they're seeking, or at least our experience of what they've been looking for and what we've been able to provide. So that's sort of my teaser. I think I'll turn it over to Santo, and then maybe we can come back and answer some questions.
Sounds good. Thank you, Joe. And thanks to the center for hosting this conversation and the work that you do around so many issues that are important to rural Minnesotans and greater Minnesotans. I think the center has a very good eye for those issues that are emerging that really affect a particular way of life. And one of the things that gives me a great fulfillment about being on the board is hearing those conversations and those issues identified, because this is really truly about preserving a way of life. And for those of you who I've had a chance to meet, you already know this. For those of you who are hearing me speak for the first time on these matters, I will share with you, I grew up at a dairy farm in western Stearns County. I was born in a critical access hospital. My fifth daughter was born in a CentraCare critical access hospital. I live in rural Minnesota by choice, not by circumstance. And for about 20 years, I lived in the metro. Ironically, the other four daughters were born in St. Joseph's Hospital, which is just recently closed. So while we talk about the pressures on rural healthcare, certainly it is something that is across the marketplace of healthcare. However, like many things that are broad and blunt, they have a disparate impact depending upon the population or the way of life you're really trying to preserve. And what CentraCare does, and what I think the center does, and certainly what RUPRI does so well, is saying there are people at the center of this that create a community that their way of life is of its own intrinsic value. People who live in greater Minnesota aren't people who haven't thought of driving down 94 or 35 to live in the 7-county metro. It's occurred to us. Some of us have done it. And the way of life we've chosen by living in rural Minnesota creates a unique perspective. And that perspective is this. I think that we all in greater Minnesota have a deep understanding of how dependent we are upon population centers. I think where there is a lacking of perspective is how dependent those population centers are on the rest of us who live in greater Minnesota for transportation and trucking, for manufacturing, for agriculture, for healthcare, for jobs, you name it. And so I think that interdependence is sometimes just slightly more appreciated in greater Minnesota than it might be in what seems to be a self-sustaining system within a metropolitan area. And so I think those of us in greater Minnesota can really feel that differential at times when, whether it be COVID-19, government programs, you name it, the policies that drive, and having been, many, many years in government, the very definition of a good law is one that applies equally to everybody. But of course, for those of us who come from different backgrounds, different communities, immigrant communities, metropolitan communities, each one of those is going to have that policy impact them and their way of life and their loved ones in a totally different way. So as we talk about these demographic shifts that are occurring, both in the age wave of the boomers who will be leaving the workforce and entering, at-home placements or long-term care or increased medical services, as we talk about the decreasing birth rate, the increased need for employment, certainly in the wake of COVID-19, but prior to, there was a great workforce shortage, both in the metro and in greater Minnesota. How childcare came along with those things. And each one of these issues, egg economy, trade, you name it, the center has done, the Center for Rural Policy and Development has done an exquisite job of having a real conversation about real difficult trade-offs that you have to make to discuss those things. So I am very excited to be here today and to have the conversation. I hope there'll be lots of chance for difficult questions and interaction, because this is a real conversation that folks need to have to preserve a very valuable way of life. Kelly, back to you. And Kelly, don't sound so surprised that I got a promotion. That was weird.
Thanks, Santo. Appreciate it. Well, for everybody that's watching the live stream right now, I encourage you to start asking questions. Use your Q&A box. We're already getting a few to come in, and we're going to get to those in just a second. I'm going to start out with one question, and it'd be great if you guys have questions. This is your opportunity to start asking them. We got some pretty good experts on here that I think will come up with some good answers for you to help move forward, maybe in your region or community, and help figure some things out. But I think to start off with, and Jennifer, we'll start with you. For our audience, we have members that are county commissioners, school board members, township members, the city council folks. These are types of people that maybe don't engage with healthcare providers as much as maybe our public health units would at the county level anyway. But from your perspective and from the research you've looked at, what government entity or local position is best to lead and facilitate relationship building with your healthcare providers, and what should that look like?
Yeah, it's a great question. And what I'll say is, I don't think there's a one size fits all. I think that everyone that you just listed and everyone that's kind of represented on this forum today is in the potential position to do that. What I will say is, in observing what has happened across the country, is if a community has a hospital, it's often the hospital that leads and is reaching out. And I think we've seen even more of that with the advent of the Community Health Needs Assessment in conjunction with the Affordable Care Act. So now every nonprofit hospital in the US has to, on a regular recurring basis, do a Community Health Needs Assessment. If those are done in a really authentic and meaningful way, they really serve as a platform for and a foundation for that outreach and that engagement that bridges healthcare and community. Unfortunately, I will say sometimes we see it done as sort of a rote exercise and check the box and meet that IRS requirement. But when they're done well, that serves as a perfect opportunity to make that connection. Because again, the hospital is often, in a small rural community, one of the largest employers, and one of the real draws to maintaining that hospital is that making those connections. So in a community with a hospital, it's often the hospitals reaching out. But we've seen so many great examples of where that leadership can come from in other instances. We did a case study, again, that you'll find on the Rural Health Value website that I referenced for you, that is in Wisconsin. And it was the health system and the school and the local city council that came together and said, we're going to do some joint strategic community planning, equally in the lead, all three, not driven by healthcare, not driven by schools, but doing that in equal partnership. So there are many examples of where that can come from. And I would just say, not one size does not fit all.
Excellent, Jennifer. For Joe and Santo, from the CentraCare perspective, have you guys seen any interesting collaborations that aren't, your typical public health officials, but rather more local elected officials or regional leadership within your system?
I'll take that in the beginning, and Joe, maybe you can follow up. But I think one of the ways that I think that some of these silos have broken down is actually on certain issue areas. So, for example, I sit along with our VP of Population Health on something called the Central Minnesota Mental Health Steering Committee. And that's over 30, 40 organizations, including the VA, police, the sheriff's office, the county attorney's office, the defense bar, the judges, public service, the jails, you name it. And boy, have we gotten far afield from our original purpose around healthcare, now trying to address and break down silos around communication of all kinds of other issues that we're realizing we're actually all spending dollars on, and how those dollars could be used better if they were more integrated and if there was more of a strategic approach, again, an unsiloed approach within the community. So I think the scales have really fallen from healthcare's eyes, and how many other community partners are out there willing and open to have an honest dialogue about how to manage people going from the jail to detox to the emergency room, and how to reduce those encounters, not just so that we can save dollars, but actually serve those individuals much, much better in an integrated way.
I think the other comment I would make is, and I don't think I've heard almost all of the healthcare buzzwords in the last hour and a half, except for social determinants of health. If people aren't familiar with that, what we do in hospitals and clinics, what all of the magnificent technology and all the expertise come to bear, is only about 20% of what constitutes somebody's health. The other 80% is factors of genetics, environment, and choices that they make. Where this really comes into play from the health industry standpoint is, as that payment shifts more towards that value and we get paid on outcomes, we only control 20% of the outcome that we can produce. And so it takes a village, it takes a community, it takes a county to improve the health of the population. And so there's a business case. Whether you initiate it from outside or the hospital or the clinicians do, there's all the reason. Number one is all of our health will improve, and two, there's a good potential for reimbursement in a new payment system. So I'll add that in as well.
Thanks, guys. So it sounds like it can go beyond the public health, but really anybody can be involved depending on what sorts of issues you want to work on. So looking at social determinants, it could be even the city planner getting involved about how the parks will be developed with your healthcare provider. It really is about everyone getting involved in this. That's really interesting. We got one question in here, and I'll throw this out. And since you guys are on Zoom, I will call somebody out to answer it, and please feel free to say pass or let me think about that next, and we could go on to the next person. That way you're not fighting over screen time and talking at the same time. The question is, how can communities work with providers to provide more or better care to the uninsured? And Joe, maybe I'll start with you on this one. And please feel free to be like, give me a sec on that. No problem.
I will pass and give me a sec.
All right. Jennifer, did you want to try taking a crack at that?
So I'm not sure I have a good answer, and my instinct maybe would be to pass as Joe just did. But what I'll say is that we saw a trajectory of increasing insurance coverage over the past decade, but now that trend is reversing, and it's particularly concerning for children. We're seeing more and more uninsured kids across the country, and including here in Minnesota. So it's a worrisome trend going in the wrong direction. I'm not sure I have any good programmatic answers to where we need to go with that. I think there's some policy responses that are important and that we can do something about here in Minnesota, in addition to what happens federally. But I do think there's some worrisome trends in this period of COVID-19 about uninsured, and especially kids who are uninsured.
Jennifer, did you want to expand on your comment about there are some policy things at the state level that could be done? What would those look like?
Well, so, I think that we have created the MNsure program, and continues to get tweaked, and we're going into the open enrollment period now. We did some things during the public health emergency here in the state where our governor opened up in different ways access to that as an insurance coverage in periods when it wouldn't have typically been in place, but because of the authority under the public health emergency that could occur. And so I think we need to be paying attention to what the data is telling us, and then where that intersects with policy responses, like being able to open access at different times other than just your typical open enrollment period, for example.
Yeah, excellent. And for Joe and Santo, maybe, if you can't answer that question directly, I think it'd be interesting to our audience to hear from your guys' perspective. What does trying to provide care to the uninsured do for your financial standing at some of our healthcare providers? Because, when we look at the data, rural hospitals in particular had to absorb a lot of non-payments for services because they can't not provide services. They sometimes have to provide emergency services and then just not get paid for it. And that can be particularly challenging in a rural area where there typically is more uninsured folks. So that might be an angle for you guys to answer that question too.
Yeah, I would jump in and just say that I think that where Jennifer was going around some of the Medicaid expansion population is really the policy, part of the policy answer to that pie. So, for example, we've seen that, the ACA or Obamacare, whatever you want to call it, was a really, really hot button issue when it first came out. Very divisive. That's familiar to all of us living in this time of division. But when you look at Obamacare, ACA, whatever you want to call it, what really crashed and burned was the rollout of enrollment in terms of healthcare.gov or MNsure, you name it. That was the part, the experience of acquiring the insurance was incredibly unpopular and had many, many issues that needed to be fixed. The public program behind that, Medicaid in many cases, and certainly in Minnesota, we have both Minnesota Care, which is defined as a BHP, a basic health plan, and we also have traditional Medicaid, which we call MA or Medicare Medical Assistance in Minnesota. Those public programs account for over 1.2 million Minnesotans. And what I want to share with folks in terms of how big this population is already, in Minnesota, just under 50%. It's probably different from the time I worked at DHS, but it's probably somewhere around 45 to 47% of all births every single day are funded by public programs. So that really goes to show what Jennifer's talking about, the veracity of there is a huge population of our next generation that is structurally dependent upon these programs. And Kelly, to your point around, if you look at the payer mix of rural Minnesotans, they're typically older, poorer, and sicker than their metro counterparts, making them that much more vulnerable when one of two things happens. Those folks, they don't get any reimbursement, so they're not actually enrolled on the program that they qualify for, like Medicaid or Minnesota Care. But then also, those reimbursements themselves do not bear the full cost of that which goes out the door. That's really where payment reform around bundled payment and value-based payment, that's really where the crux of that is coming from a dollars and cents standpoint. Because when you look at the all funds budget of just Minnesota, it's somewhere between 45 and 47% again of the entire state controlled budget goes to health and human services. A big, huge portion of that is the Medicaid population. If that huge part of the pie is not actually sustaining the services that are provided in it, which they're not, then we can't ask for people to do even more with even less. We really have to fundamentally change the incentive and the sustainability of those public programs. And that's something that I think the state is well aware of and is on that journey now.
Excellent, thank you. Got another question come in here. What's the value of county-based models of rural healthcare delivery? So county-based purchasing, working closely with rural providers and locally addressing access and care need issues. Any experience in that? And I'll start, maybe I'll start with Jennifer on that one.
Yeah, the response that comes immediately to mind for me is that county-based purchasing, which we have in Minnesota and is not very prevalent in other parts of the country, is an opportunity to break down the silos of payment and intersection of social services and healthcare. And that to me is the real advantage of thinking about having the counties, which have the county caseworkers and public health, also right there in the mix of healthcare. And that's so much of the experience that we have in those places that don't have that, is that we have these big silos that people want to do the right thing. And they recognize that, Joe was talking about social determinants of health, how important it is to address those social needs that many community-based organizations or that come from social or human services sit right alongside with the medical needs that come from the care system. Yet those payment streams and those funding sources have such requirements and strictness about them that we want to do a lot more collaboration than seems feasible because of those boundaries and barriers. And so one of the advantages of county-based purchasing and thinking about the county as being home to those activities, serving as the Medicaid health plan and as the county social services agency, is there's, even if the funding streams aren't broken down, there's at least the opportunity for some integration and intersection of those two.
Have you witnessed any kind of experiences and barriers or any ways in which it can be a disadvantage to have this type of model?
Well, of course, there's all the challenges that come with all those kinds of things. I think payment is often a challenge in that model. And I think when it's often only Medicaid and the county doesn't look at the full spectrum of care needs across their community populations. They're just more narrowly focused on a particular eligibility criteria for Medicaid funding, for example.
Yeah, okay. Joe and Santo, any response to the question?
I would defer to Santo. He's the policy guy.
I don't want to, we're at a time of you want to make sure there's equal time in terms of we're in that election season. So while I'm not certainly not running for anything, I would say that Jennifer really framed it really well in terms of what's great about that model is the ability to break down some silos. What then needs to be accounted for in that model is what are the incentives in terms of what is that county struggling with? What is that population struggling with? What is their needs? So I think it's definitely a model that solves many issues, but at the same time is not free from its own challenges. And that's really true across the board. There's not, if there were a magic bullet, we would have discovered it a long time ago in healthcare. But the reality is, because it's such a personal experience and personal need around healthcare, while at the same time involving such huge dollars and public policy, getting that balance right for the individual is always a challenge. So we all are committed to being patient-centric, but that is through a lens of multiple regulations, incentives, and I would just offer one small window into that. When you hear that rural hospitals are struggling financially, I think that's really hard for farmers to believe when they get their bill, because they look at their bill from a hospital, and I'll use a Zoom appropriate term, the tick off factor is through the roof when you get that bill. And you go, how are they struggling that this is the case? One of the challenges with running a not-for-profit health system, and certainly a hospital, is that your entire supply chain is for profit, in virtually. And they are coming out with brand new, amazing things all of the time. And no one wants, at least I've not heard of really anybody volunteer 4 or 5 models ago of a stent in their heart. They want the latest, greatest, best thing that is out there. And that creates an incentive in the marketplace for every hospital that offers those services to make sure that they are meeting not just network adequacy, but the latest, greatest, best that's out there, so that those patients can have that conversation one-on-one with their provider, and they can say, this is the best healthcare for you we could come up with. There is a cost to that. And that cost comes through a lot of companies that are wonderful companies that we're blessed to have in Minnesota, but that are traded on the public stock exchange. We are not, as a not-for-profit. We are required, if we, to have a mission, and to make sure that we do not have shareholders that are, and we don't trade on the stock exchange and the like. It is not to say that they are evil and we are good. It is merely to say that entire framework of the stock market, and between 16 to 20% of the entire economy being healthcare, eventually makes its way to you on your farm when you look at your bill and go, holy cow, these people are struggling financially. Look what I just got charged. And so that is a very big challenge in healthcare.
So, this whole conversation is about trying to bridge the gap between the general public and kind of what you're talking about, Santo, which is, people just not fully understanding the arena and environment in which our healthcare providers are working in, and trying to provide the best services they can, and to try and bridge that gap and have these conversations from your guys' perspective. And we'll start with you, Santo or Joe. In what ways do you feel like state government could help support more collaborations among local entities to help start bridging this gap a little bit and have these conversations about the future of rural healthcare access? Is there ways in which you feel like this would be really nice if there was a state program for this, or some sort of support to help these conversations? We do have the community health needs assessments, obviously, and that's the federal government thing, but that really is between the public health and kind of the general public, and not so much the providers per se. I'd be curious from CentraCare's perspective, and Santo, how you feel about where that support could be.
Oh yeah, and I think to be honest with you, if we're going to ask our policymakers to enter into this space, to create this venue for us to have a more systematic approach and dialogue, which I think is a good idea. Many of them want to, but quite frankly, healthcare has made fools of everyone who said they were going to fix it. And so what we need to understand is that everybody who wants to, quote unquote, fix healthcare needs really 2 things. 1, some breathing room, and 2, some really deep understanding. I think there's a lot of legislators, I know a lot of legislators, who want to be more involved in healthcare. And what happens is they invite someone like me into their office. And what ends up happening is they spend all of their time basically just having a 55-gallon drum of facts poured out over their lap that says why their idea doesn't really work, or why it changes the incentives or something like that. And to be honest with you, what really is needed for that to be successful is for it to be okay for a legislature to fail. And as we know, in a popular democracy, that clearly isn't. because the moment they are for something that ends up not working out, then it gets into a 5x7 card in everybody's mailbox around election season. And so I think that there has to be a higher tolerance for trying things out that maybe don't work. And in particular, the mechanism for that probably at the state level is through an increased amount of pilot programs. Pilot programs aren't really expected to succeed 100% of the time. I think there is at least some political consequence for a pilot program failing. But ultimately, we need to give our policymakers the breathing room politically to really try and grab the reins of some of this conversation.
Yeah, thanks, Santo. Jennifer, I know you kind of have a more broad look of looking at all the states in the country. I imagine this conversation is happening all across America. Have you experienced or witnessed or done research on state governments that have tried to help support these conversations and these collaborations in unique ways?
Yeah, I'll offer an example from another part of the country. And then I actually have 3 specific things for Minnesota that are very tactical and go down to a much narrower level based on Stratis Health's experience in our rural work here in the state. But my answer to what's going on across the country is to be paying attention to places like Vermont and Maryland and Pennsylvania, where they as states have moved toward global budgeting programs, which bring together all payers, so Medicare, Medicaid, and commercial, and create for their rural providers, including and especially their rural hospitals, a more steady revenue stream to support financial sustainability in exchange for transforming how care is delivered and doing that in ways that really bridge healthcare and community. So the Pennsylvania Rural Health Model, the Vermont Blueprint for Health, there are some really innovative things that are happening at state levels that I think we in Minnesota should be keeping our eye on. But my very tactical answer, so Santo gave this great answer about kind of big policy. I have a little policy. I think we would benefit tremendously in rural Minnesota if there was a statewide registry for advanced care plans and pulse, and that was available not only to healthcare providers, but community organizations and faith leaders. I think we would be greatly advantaged if there was a SHIP 2.0 or 3.0, where we have public health priorities identified that, you know, in the first go around, it was a lot focused on obesity and on behavioral health and on chronic disease. Those are all still with us, but boy, we could do well if there was pandemic planning and emergency preparedness added to that list. I also think we've done some good work in Minnesota and can take it to the next level about using community health workers and community paramedics and different kinds of workforce in rural healthcare that, again, help build that bridge and help us address social determinants of health. So 3 very little small p policy changes that could be really helpful in our state.
Awesome. Thanks, Jennifer. We got a question here. I think just a very straight up basic question. Now we'll start with our CentraCare folks. What do you need most from local community leaders right now, this time? What do you need most to have these conversations and to start building relationships and really change what access looks like in rural Minnesota?
What do we need most? Engagement. You know, it's been said before, but the hospital, the clinic are interwoven in the fabric of rural communities, and they're really important. It's what separates one town from the next. And I think people need to be engaged. They need to find out what's going on in their hospital, how they're doing, what their vision is, and they need to be there to help form that vision. So I would say that is primarily what I would be looking for. I think in terms of looking for partnerships, it's to be clear about what it is that the community and most of the hospitals that are left that are independent are some sort of either county owned or municipal. There are some quasi government, perhaps a district, and so I think it's well within the public forum and to take part in all of that and to begin to drive that. And I think you want to look at what it is that you want to preserve, what is it that you want to enhance. And it used to be that we were very much driven by the need for capital. And a lot of that still is out there in Minnesota. But I think more and more it's being driven, partnerships are being driven by the need for competency, expertise in areas that is difficult to come by. So that would be my answer.
Joe, kind of a follow-up to that. I'm curious. Let's say I'm a city council member, and I'll just use my town, New London, Minnesota. We have Caris Health. We have a clinic just outside of town, and then we have the larger kind of specialty and hospital in Wilmer, which is about 20 miles away. And I was a city council member, and I really wanted to find out like what relationships are being built with my healthcare provider in the region, and how can I join up or link in. Where would I start?
I think you'd start by contacting that local administrator and showing your interest in that as a community leader, as a government official. And I can't imagine anybody that would turn that down. Santo, I'll just see if you have any thoughts on that are different.
You know, there are times where someone has a community relations or government relations individual, and I would say those are always a good place to start. But you know, I go back to Jennifer's point about there's the check the box. We call it a China, or the community health needs assessment. There's the check the box community health needs assessment, and then there's the spirit of the community health needs assessment. That process for those that are taking that seriously is a great place to plug in, because it balances the conversation, not just of the engagement that Joe talks about that we need in healthcare, but also the data that the county public health officials have, the community leaders have. And so I think that the community health needs assessment is a great example. One other thing I'd mention around this issue of what we need most right now, I would say an understanding of what the disruptors are actually intending to do. The disruptors of healthcare, you know, the iPhone, and people say Amazon's in healthcare, and you name it. All of the disruptors, when they come, you know, riding into rural Minnesota, they are very unlikely to come to the low reimbursement, high value areas that rural Minnesota is already struggling to meet. By that I mean, if you are going to disrupt healthcare and you are a part of a venture capital, and you look at the reimbursement model and the incentives that exist in the Medicaid, Medicare, and commercial budget, and you say, I want to do addiction medicine and I want to do mental health treatment, your venture capital folks, angel investors, will look at you, and you know, it'll be like an awkward moment on Shark Tank. The episode is over right there. So what do systems really bring with their scale? We cross-subsidize those things that aren't reimbursed at a sustainable model. So as you peck away at those independents or those systems, whatever it is in rural Minnesota, those disruptors, you're not going to see it vertically integrated where they have their loss. You're going to see mental health beds go away. You're going to see a substance abuse treatment go away. These areas that have been cross-subsidized by the higher margin, higher incentivized practices. So it is very important for both policymakers, local government leaders, hospital administrators, if they're independent and you name it, realize that disruption is not something that we're going to be able to control, but it is something that we're going to have to navigate. And navigating that really requires a real clear-eyed view that cross-subsidization is the current norm, regardless of what you're talking about. So you might say, well, you know, they came in and it was just the little minute clinic. Why are we losing mental health beds? Well, because there was a high volume of very easy primary care visits that those doctors were able to do. And now the folks they're getting are much more complex, are much more acute. And the reimbursement is the exact same for that visit as it was for the ones that just went to the CVS. Again, does it make those disruptors bad? No, it doesn't. I'm a free market person, and people can absolutely innovate, and we need that. But in rural Minnesota, we got to be very clear-eyed about what those trade-offs are going to mean.
Right, right. Well, I know Santo and Joe, you guys had something come up just in the past day. It means you have to depart at 11:50. I want to give you one last opportunity here to say any last thoughts, any clarity you want to add to the conversation before you guys need to take off, and then we'll continue our conversation for a few more minutes with Jennifer.
Yeah, I do apologize for needing to jump early, and certainly through the being on the board of the Center for Rural Policy, thank you very much. But people can reach me and ask me follow-up questions. But I actually want to go back to something Jennifer said around her three micro policy things. I endorse those wholeheartedly, and I don't think they're micro at all. I think those are three real serious wins for rural Minnesota. If you look at where the cost is in healthcare, without a clear directive, our default setting is we will do everything possible. And so that's why getting those advanced care directives and your wishes articulated is so important. And everything else she has said has really been spot on. So you're in very good hands, even with the CentraCare team needing to leave early, but we can be tracked down pretty easily as well.
Thank you, Santo. And thank you, Joe, for joining us as well. Really appreciate it.
Yeah, thank you. I think I wanted to just touch base on a couple things in a broad concept. The economies of scale that we talked about are really important, and healthcare is the business of healthcare is big business, and it's high tech, and we struggle all the time to try and maintain. At the same time, it's very personal. The delivery of healthcare is very personal, and rural communities, just like urban communities, need to grapple with that. But particularly in rural, how do you preserve? And this is what we work with every day, trying to solve for this equation. How do you keep it personal and still be able to deliver the quality and the technology that people expect? So I'll leave it with that.
Thank you, Joe. Really appreciate your time. Take care. Jennifer, we're gonna continue our conversation a little bit longer with you, if that's okay.
That's great, thanks.
So, through our questions that we're receiving here, we're getting a lot of comments about, what are some examples of how community has collaborated with a healthcare provider on increasing services to those always challenging specialty care, addiction services, dentists, things like that. Have you seen or read anything interesting that you could relate to our audience here about, what has worked well, maybe somewhere else? Or
Yeah, and even what is working well right now in Minnesota, we are in the midst of a large-scale national experiment on telehealth. So those who have been advocating for telehealth over 20 years now say that more has changed in 2 weeks or 4 weeks in March and April than they had been pushing for over decades. And it's really true, again, both here in Minnesota and across the country. And we often think about in rural telehealth bringing access to what you just asked about, Kelly. So telehealth can bring specialty care that isn't available locally. Telehealth can bring addiction, behavioral health that isn't available locally. But what I would say is that we've also seen telehealth now being used by those primary care and family practice clinics in rural to meet the needs differently of their patients and families in rural communities. So it's not only accessing the type of care that wasn't available before, but it's actually reconceptualizing what care looks like today, even in those that would be otherwise available in person, but for reasons of transportation or infection or risk, or when things were shut down and you couldn't do elective visits, we've seen really this big shift in how telehealth is being used in rural. And to me, that's really promising. It has been accompanied by innovative programs like Hospital at Home. We know that in Ely, the Essentia Health System is in the midst of a pilot to say, are there certain acute conditions that otherwise would have been hospitalized, but we can actually treat them at home if we think differently about how that care is delivered? Or in Lakewood Health System and Staples, they're really thinking about palliative care services and then thinking about, okay, can we put a telehealth room in the library? Can we partner differently with community agencies? Can we partner differently so that we're still getting care and services out, but the pandemic has been and continues to be a really stressful situation with so much illness and death associated with it. But the silver lining is it's forcing us to do things in ways and rethink care delivery in ways that we never would have imagined a mere 6 or 8 months ago. So I think there are some promising things that are coming out around the use of technology, and particularly telehealth, that will help us be on the cutting edge and be innovative in rural and keep those services and access local.
You talked a lot about, this kind of shift, and I think a lot of it, the initial barriers to taking on telehealth were a lot of social barriers. So people just not wanting to do it, didn't know how to use the technology. There might have been some technological skills gaps, but the pandemic has kind of forced that hand a little bit and said, people just get over it. We got to figure this out. Now I imagine, maybe I'm wrong, but there might be some new barriers that are cropping up, things that we haven't thought about now that we're implementing at full scale. What are some of those barriers? What have they been that you've seen?
Yeah, so a couple of things come to mind. First of all, there's been this new set of regulatory flexibility around telehealth. So for the period leading up until March, before the public health emergency, you could not be reimbursed as a clinician for a telehealth visit by telephone. Now you can be. You can do audio only visits. That just opens up a whole new realm of availability for people that either cannot use or don't have the device that would allow a video connection. And for those that don't have broadband, we still have spots in Minnesota. We still have spots in other parts of the country that don't have broadband. And even when broadband comes in, it's sometimes not affordable for those patients and families. So again, understanding that, okay, we'd love it if there was video connection for telehealth, but guess what? We're figuring out ways to make it work audio only. So that's an example of being attentive to the environment and understanding that that's sometimes the most responsive to patients' needs in addressing what their abilities or limitations are.
So another question that just came in, Jennifer, and I think it's a really interesting one. So kind of acknowledging like systemness, this idea of systemness, we're going to have a system. That's just kind of the way rural health or healthcare is moving. How do we keep that in a manner that is locally responsive, accountable, and locally driven? How to maintain local population sensitive responses to unique needs and rural needs. It's kind of what we've been kind of talking about, and I'm curious what your answer is to that.
Yeah, I can respond, and I wish Santo and Joe were here with us as well to kind of reflect on it from the CentraCare experience. I think there's just wide variation in how much that occurs. And the reason has been for if a health system comes in and takes, there's an affiliation or there's a merger with a hospital or a clinic. If that's done out of, call it financial desperation, then often that the system that's coming in is in the driver's seat, and the kinds of considerations that they might negotiate about local control and what a local board of directors looks like and what decisions are local versus at the system level are really different than when, again, I described to you that we have some case examples on the Rural Health Value website. There's case examples on there where rural communities have come together, maybe in a region. There's an example of 3 hospitals coming together in Oregon and doing an RFP for affiliation and laying out their criteria and saying, we want to be in the driver's seat because we know we want that scale that Joe was just talking about, but we also know that we want certain aspects of decision-making and local control and local authority and local engagement to stay here in our local community. So we're going to set the parameters for what an affiliation or an acquisition looks like. And so, again, I think there's a lot of tension there because part of why you get scale is because you do some things in standardized ways. And that sometimes is a point of tension or disagreement with what the local community might need or want. So I just think there's an enormous variation in the reasons why those mergers and acquisitions or affiliations are occurring, and then who and how those are negotiated in terms of where the local control sits and where it doesn't.
Oh, that's really interesting. I think that's a really cool example. But a quick follow-up to that, have you seen any state policy that tries to implement that if there are any mergers or affiliations or acquisitions, that there has to be a system set up for local input, or maybe making it that there has to be a local member on the board of trustees or anything like that you've seen?
I've not seen that come as state policy, but I'm fairly sure I don't have a comprehensive view of what that would be. It has not popped up in either our Rupri Health Panel work or our Rural Health Value work, so I can't speak to that. I think that's another interesting thing to put on our list, though, to your prior question about what state policy, either capital P or lower P, might be able to do.
Right. Well, we have hit 12 o'clock. I want to end this with Jennifer. Thank you so much. Your expertise was fantastic on this panel. I encourage anyone, I imagine they can reach out to you. You'll be sending us the slideshow, which we have. So we'll be sending that out to our audience members, and really appreciate your time, Jennifer.
Great. Thank you so much. It was a pleasure to be with you all today.
Take care. Well, that is it for us. As I mentioned, we'll be sending out our slideshow presentation to the attendees of this. And for folks that are maybe viewing this that weren't able to attend today, viewing it at a later time, please reach out to the Center for Rural Policy and Development. Our general email is on our website, and we'd be happy to send you all the materials and research and everything that you might need, and love to answer questions. With that, I want to thank Heather and the Association of Minnesota Counties and everybody that joined us today. Really appreciate your time. Sourcewell IT crew, thanks a lot. This was a lot of fun, very unique and different for us, but we really enjoy it, and have a great day.